Welcome to the Great Adventure, Pediatric Pulmonary Physiology. This is the 26th presentation in a series of 30, and we're going to be talking about exercise physiology, part 2. So this is the Great Adventure. We want to approach this with the enthusiasm of a child in a candy shop. And so today, we're going to talk about the respiratory response to exercise. People oftentimes talk about the cardiac response, aerobic training, limitations to exercise-induced bronchospasm, and then just for fun, a couple of studies about exercise in chronic disease, and then finally we will summarize what we've learned about exercise. So first, the respiratory response. How do you increase ventilation in response to exercise, or why do you increase ventilation in response to exercise? This was thought to be mediated by central and peripheral chemoreceptors, but there's one problem with that theory. And that is that exercise hyperpnea begins before blood returns from exercising muscles to the chemoreceptors. Ordinarily, PO2, partial pressure of oxygen, does not fall during exercise in normal individuals, and PCO2 does not rise. So a decrease in oxygen or increase in CO2 are abnormal and indicate pulmonary limitation exercise. Is precise gas exchange maintained by chemoreceptors? So we have an experiment of nature. Children with congenital central hypoventilation syndrome do not have normal hypoxic and hypercapnic ventilatory responses even when they're awake. Jimmy Payton and Soumya Swaminathan, postdoctoral fellows in pediatric pulmonology at Children's, performed some studies. They looked at a number of children with congenital central hypoventilation syndrome and performed the rebreathing hypercapnic ventilatory responses. We've talked about those before, and here you can see the results in 5 patients. So minute ventilation is plotted against end-tidal CO2 or alveolar CO2, and for each of the 5 patients you can see individual results. There is no linear increase in ventilation in response to increasing PCO2. In fact, these are all shotgun blasts. I mean, there's no relationship really between ventilation and CO2. Similarly, they measured rebreathing hypoxic ventilatory responses, and again, minute ventilation plotted against arterial oxygen saturation should be a linear increase in ventilation as saturation falls, and you can see here no identifiable pattern. These are basically random. In some patients, for example here, it looks like hypoxia actually decreases ventilation rather than increases it. So these patients don't have hypoxia or hypercapnic ventilatory responses. In fact, the correlation coefficients between end-tidal CO2 and ventilation here and arterial oxygen saturation and ventilation here are all statistically not significant. And in fact, most of them occur in the wrong direction. Hypercapnic ventilatory response should be positive, and you can see that 2 are negative. Hypoxic ventilatory responses should be negative, and you can see that 4 are positive. These patients have no ventilatory response to hypoxia or hypercapnia, or essentially, they don't have adequate chemoreceptor function. Yet, parents of our CCHS patients will say that they seem to exercise fine. They can go to school, they can run across the playground, they don't suddenly drop and turn blue in the middle of the playground. So what is going on? Do these CCHS patients without chemoreceptor function have abnormal gas exchange during exercise? Do they increase minute ventilation in response to exercise? And if so, how is this ventilatory response to exercise mediated? So we performed graded cardiopulmonary exercise stress tests on 5 individuals with CCHS and 9 controls. So what's plotted here is maximal heart rate, you can see, was statistically significantly lower in CCHS, but this is a sign of this condition. Maximal RQ ratio, there was no statistical difference, and maximal oxygen consumption, mLs per kilogram per minute, although CCHS was slightly lower, was not statistically significantly decreased from controls. So this represents the gas exchange. Controls are in the red bars, CCHS the orange bars, and you can see that oxygen saturation in normal individuals really changes very little, but in CCHS it drops about 6%. Now, it is statistically significantly different than controls, but it's not a severe, serious gas exchange abnormality that would be anywhere near fatal. Trace stainless O2 also fell in the CCHS patients, about 13 or 14 torr, did not change in the controls, but again, not a significant change in terms of clinically significant. And finally, CO2, transcutaneous CO2 increased about 10 torr in CCHS and did not change in controls. Again, abnormal, but not something that would be a potentially life-threatening gas exchange abnormality. So the answer to the first question is that CCHS patients do have some, what we'll call minor gas exchange abnormalities in exercise. So do they increase ventilation? So here, minute ventilation is plotted against CO2 production, which should be linear. And you can see that the controls in red increase and the CCHS patients in orange also increase, though the slope of their increase is statistically significantly lower than the slope of the controls. I think the most important finding here is, however, that in the absence of chemoreceptor function, these individuals actually do increase ventilation in response to exercise. Here you can see tidal volume plotted against minute ventilation, and it's known that CCHS patients have a relatively constant tidal volume, and therefore it's not surprising that they increase tidal volume less than controls. But again, they do increase it. So this just shows the cumulative data. So tidal volume increased maybe only about a third. What controls do was statistically different. Respiratory rate consequently increases more in CCHS than controls. Minute ventilation, not significantly different, although the minute ventilation is lower, though not statistically so, than in controls. So how do they increase? One of the things that we thought was maybe they increase ventilation by basically entraining their respiration to their activity. So we looked at minute ventilation in terms of paces per minute on the treadmill. And as you can see, and your grandmother could tell you, the faster you run, the harder you're going to breathe. So this is not particularly surprising and doesn't really prove anything. If we look at paces per minute versus respiratory rate, we see the same thing. Respiratory rate increases linearly with paces per minute. Again, not surprising. So how are we going to prove that respiratory rate is in fact what improves? So what we did was take some of our CCHS patients and exercise them on a treadmill just about at their anaerobic threshold. So just below that, so this is exercise that theoretically could be performed indefinitely, a so-called submaximal exercise. We ran them on two conditions. In one condition, the treadmill was flat and ran fast. In the other condition, the treadmill was at a steep angle and went slow. We matched the metabolic rate. And so you can see here that in the two conditions, slow steep in red, fast flat in orange, the metabolic rate as oxygen consumption was essentially the same. By design, paces per minute were slower in the slow steep than the fast flat, and the respiratory rate tended to track that. It was a bit slower in the slow steep and a bit higher in the fast flat. Tidal volume was not different, and so minute ventilation was actually increased more in the fast flat condition than in the slow steep condition. So this suggests that body movement may in fact be something that does improve ventilation during exercise in these patients that do not have chemoreceptor function. So David Gozal, who was a pulmonary fellow in 1990 to 1993, did a slightly different experiment. In this case, we constructed a bicycle ergometer which was motorized and would passively move the legs. Now note that this was designed to actually pedal backwards so that the subject would not even unconsciously pedal with the bicycle. And we could change the frequency of this from 0 to 60 revolutions per minute. We measured their breathing, gas exchange, pulse oximetry, and electrocardiogram. This is a picture of the actual device and one of our subjects, and you can see we're measuring her ventilation here, and we're moving her legs on the pedal here backwards. Respiratory rate. If we increased or when we increased the revolutions per minute greater than 30, you can see actually that both in controls and CCHS, the respiratory rate increased. Okay, so it looked like it was being entrained by the leg movement, which was passive. Tidal volume didn't really change in either controls or CCHS. Minute ventilation tended to follow respiratory rate, and therefore in both controls and in CCHS patients increased above 30 revolutions per minute. You can see a substantial increase there. And gas exchange was affected in the CCHS patients, and tidal CO2 dropped when ventilation increased above 30 revolutions per minute, whereas the controls had no real change in end-tidal CO2. So what does this tell us about the respiratory response to exercise? In CCHS, patients without chemoreceptor function, P arterial O2 and P arterial CO2 are not precisely controlled, but they're not severely abnormal. Minute ventilation increases during exercise, and we believe that body movement is what actually increased ventilation, so-called mechanoreceptors, which have been documented in animals. Now, this doesn't just tell us something about a rare genetic disorder. It also tells us something about the respiratory response in normal individuals. So in normal individuals, body movement initially gets ventilation into the right ballpark. This is before blood returning from exercising muscle has time to reach the chemoreceptors. But the mechanoreceptors presumably start your increased breathing and get you in the ballpark. Chemoreceptors, which were absent in CCHS, fine-tune minute ventilation to precisely control PaO2 and PaCO2. So, interesting study in CCHS, which told us something about how ventilation is controlled during exercise. So, CCHS patients without chemoreceptor function have fair gas exchange. Mechanoreceptors get VE in the ballpark. Chemoreceptors fine-tune PO2 and PCO2, and redundancy of crucial physiologic systems is necessary for optimal performance. Let's look at aerobic training. So aerobic training is muscle specific. Oxidative enzymes and mitochondria increase in muscle cells. This requires an increase in O2 delivery to the muscle by increasing cardiac output, primarily by increasing stroke volume. This increases the maximal oxygen consumption and anaerobic threshold. And as we mentioned, there's no respiratory response to training. So if we plot heart rate versus workload or oxygen consumption, with aerobic training, you've increased stroke volume and therefore increased cardiac output at the same heart rate. So anybody will achieve maximal heart rate at maximal exercise. But if your stroke volume is greater, you produce a higher cardiac output, and consequently, your max O2 consumption or workload is going to be greater. So there's increased oxygen consumption at the same maximal heart rate. Aerobic training, muscles can make more energy. Increased oxygen delivery, therefore, occurs to exercising muscle. There's an increased anaerobic threshold, increased maximal O2 consumption, and a lower heart rate and minute ventilation at similar submaximal workloads, that is, submaximal below the anaerobic threshold prior to training. And that's seen here. If this was the old anaerobic threshold here, pre-training, so you can see that heart rate actually is not plotted, but minute ventilation can be somewhat lower at this range between the old anaerobic threshold and peak O2 consumption, just because of cardiovascular training. Pulmonary reserve exists at maximal exercise, so ventilatory muscle fatigue does not limit exercise, at least at sea level. There's no direct ventilatory muscle training with aerobic training, and a decrease in minute ventilation workloads above the baseline AT does occur, which may decrease complications of increased ventilation in people with diseases such as asthma. So aerobic training increases oxidative enzyme activity in exercising muscle. It requires increased oxygen supply to exercising muscle, which increases maximal cardiac output. Pulmonary reserve exists at maximal exercise training, so there's maximal exercise, so there's no pulmonary training. And it's all measured as an increase in maximal O2 consumption and anaerobic threshold post-training. What about limitations exercise? So we can test for limitations for exercise in incremental exercise stress tests. In an incremental exercise stress test, workload increases steadily. Physiologic parameters are measured, which measure fitness, and we can separate cardiac and respiratory limitations to exercise. So again, cardiac output increases linearly with workload, and then cardiac output is determined by heart rate. That is, stroke volume increases very rapidly, so that most of the increase in exercise and cardiac output is due to an increase in rate. Normally, maximal heart rate is achieved at maximum workload, and normal limitation of exercise is inability to deliver more oxygen to exercising muscles. That is, inability of the cardiac output to increase any further. Now, the red line represents a normal. If somebody has cardiac limitation to exercise, a classic example might be dilated cardiomyopathy. So the stroke volume is decreased. These individuals will still get to a maximum heart rate, but they'll do so at a much lower workload or max VO2 because the stroke volume is less and therefore the cardiac output is less. Pulmonary limitation, shown in the green line, will actually track the normal line, but it will stop sooner. Because patients are limited by pulmonary mechanisms, they don't get to maximum heart rate. That is, they have to stop before that time occurs. And so this curve for pulmonary limitation would look like this. In all honesty, we could often tell how exercise is limited just by using this graph. If we look at the gear model of Wasserman and Whip, things that limit exercise pathologically would be, in terms of the lungs, obstructive or restrictive disease, chest wall abnormalities, infiltrative lung disease. In the pulmonary circulation, thromboembolic phenomenon, vasculitis, primary pulmonary hypertension. In the heart disease, coronary, myocardial, or valvular, or anemia will decrease oxygen delivery. Peripheral circulation, occlusion, hypertension, vasoregulatory asthenia. And in the cell and mitochondrial obesity and airflow obstruction, decrease utilization of oxygen in the mitochondria and in the cell. So limitation exercise can occur in a number of places. In cardiopulmonary exercise stress testing, we can broadly define limitation as being due to cardiac or cardiovascular mechanisms or pulmonary. Now, normal individuals are limited by cardiac limitation. That is, if you gradually increase exercise, everybody has to stop at some point in time. So there is some limitation. And the normal limitation is cardiac. Remember that the heart gets to maximal cardiac function before the lungs get to maximal ventilation. So pulmonary limitation is not normal. ECGs could be abnormal with cardiac limitation. They would tend to be normal in pulmonary limitation. Max heart rate is achieved here, would be decreased in pulmonary limitation. Breathing reserve is normally about 20 to 40%. It would be less than 20% in pulmonary limitation. Ventilatory equivalent for oxygen, that is, the number of liters you must breathe to consume a liter of oxygen, is less than 40 in prepubertal children, less than 35 in postpubertal. And in pulmonary limitation, it's going to be greater than 40 or greater than 35 in postpubertal individuals. Oxygen saturation should remain greater than 95%, may fall in pulmonary limitation. End-tidal carbon dioxide should remain less than 40 and may rise in pulmonary limitation. So these are roughly the guidelines that are used to decide on a graded exercise stress test if someone is pulmonary limited or cardiac. So aerobic exercise is limited by the inability to deliver any more oxygen exercising muscle. Normal individuals reach maximal cardiac output at maximal exercise. Normal individuals are limited by cardiac limitation. Pulmonary limitation exercise is abnormal, generally due to a respiratory disorder. Exercise-induced bronchospasm. An exercise provocation test is actually most useful to document exercise symptoms. The original Chiat protocol required exercise at a maximum heart rate of greater than 170 for 6 minutes. Free running or uphill treadmill running provoke exercise-induced bronchospasm the best, and children may have difficulty performing maximal expiratory flow volume maneuvers after maximal exercise, especially at the 5-minute mark. Different types of exercise are more effective at provoking exercise-induced bronchospasm. Free running is the best. Treadmill running is second. Bicycle, not quite as good. Swimming, not so good. And walking, not very good at all. So for an exercise stress test, subjects run on an inclined treadmill for 6 minutes. They aim for 80% of their max heart rate and then measure spirometry at 5, 10, and 15 minutes after stopping. Now, I have to say that almost nobody can actually do this. Exercising at 80% of max heart rate for 6 minutes is extremely difficult, and really only very, very highly motivated athletes can do that, but you kind of do your best. What's plotted here is percent change from baseline peak flow during and after a 6-minute exercise bout, and then at basically 5, 10, and 15 minutes following exercise. So as mentioned, normal individuals slightly bronchodilate during exercise to reduce airway resistance and reduce work of breathing. Following exercise, there really is not a change. Asthma is characterized by bronchial hyperreactivity. So therefore, they actually can increase their bronchodilation more during exercise, but it falls primarily after exercise. Now, obviously, some people will have a fall starting immediately, but this at least is kind of the classic sort of approach. So if we were to measure spirometry, pre and post exercise, the red might represent an individual in a baseline state, here slightly obstructed, and then following exercise, the obstruction is even worse. So that would be exercise-induced bronchospasm, and this would be what it would look like on the flow volume curve. Here we have slight obstruction to begin with, but it gets worse following exercise here. So these were pulmonary function tests performed in a study by Meyer Katan, who was a pulmonary fellow at the Hospital for Sick Children in Toronto. This is normal values that occur at 5, 10, or 15 minutes following a vigorous exercise test as described. So peak flow falls 1.4% plus or minus 5. So the abnormal range is greater than 10% fall. So less than a 10% fall is normal. FEV1, about a 0.3 plus or minus 5.7 fall. So the abnormal range is greater than a 12.5% fall. FEF 2575 is not quite as reproducible, so it falls 2.1% plus or minus 12, and its abnormal range is greater than a 26% fall. FEF 50 and 75 are also shown, but these are not generally used. So we tend to use these three. So it looks like peak flow and FEV1 are the most sensitive to the detection of exercise-induced bronchospasm. So these are data, again, from Dr. Katan in normal, shown in blue, and in a group of severe chronic asthmatics who were defined as daily systemic steroid dependent. And you can see that their decrease in peak flow was around 18%, where normals are 1. Decrease in FEV1 about 16%, where normals are 0.3. Decrease in FEF 2575 around 25%, where normals 2. You can see that children with asthma as a group shows very significantly different values. Which test is the best at detecting exercise-induced bronchospasm? If we looked at this and we used the normal range determined in Dr. Katan's study, 83% of asthmatics who responded had a decrease in peak flow. 84% had a decrease in FEV1. 70% had a decrease in FEF 2575. If we took a significant fall in either peak flow and or FEV1, it detected virtually all patients. All right, so why? FEV1 and peak flow reflect largely large airway function. This is where bronchosmooth muscle is, and this is where you would expect bronchospasm to occur. Tests reflecting large airway function are the most sensitive at detecting bronchospasm. If you're performing exercise provocation tests, if a child shows exercise-induced bronchospasm, always give an inhaled bronchodilator to reverse bronchospasm before leaving the lab. This prevents a late asthmatic response, which is due to inflammation, usually occurring 6 to 8 hours later, and is more difficult to treat. So I never want someone leaving the pulmonary lab in worse situation than they came in. So normally, bronchodilation occurs during exercise to reduce airway resistance in normal individuals. Minimal airway obstruction normally occurs following exercise. 75% of people with asthma will have bronchospasm following intense exercise. Or maybe I should say only 75% of people will have bronchospasm following intense exercise. Running is the type of exercise most likely to provoke exercise-induced bronchospasm, and exercise-induced asthma is asthma. It is not a separate disease. It turned out that airway hyperactivity, of which exercise-induced bronchospasm is an example, is common in children who had neonatal lung injury. So David Botter studied a number of children who had BPD as infants. They were age 10 at the time of study, compared them to 8 controls. You can see their gestational age was less than controls, birth weight less than controls. They were, obviously, the controls were not on a ventilator or oxygen, and the subjects were for a bit over a month and for about 3 months on oxygen. They did have some changes evident at rest. The BPD babies had a decreased vital capacity compared to controls and an increased RV. They also had an increased RV-TLC ratio, decreased FEV1, and decreased FEF 2575. They also had Vmaxes. We've talked about those that were decreased at the 80, 70, and 60 levels. During graded exercise stress test, maximal heart rate, note the axis here, was not statistically different, nor was the maximum R that they achieved during exercise. Aerobic capacity was not significantly different. And I should mention these were BPD subjects who were not coming to pulmonary clinic. They were essentially asymptomatic in their view. Minute ventilation was slightly less. The ventilator equivalent for oxygen was not significantly different. Baseline saturation is not significantly different. Saturation during exercise not significantly different. Basically, what you can see is that 50% of BPD children met the criteria for exercise-induced bronchospasm compared to none for controls. Thus, compared to controls, adolescents who had BPD in infancy had airway obstruction, hyperinflation, normal aerobic capacity, decreased ventilation at maximum exercise, decreased saturation, increased PCO2 at maximum exercise, and exercise-induced bronchospasm. Swaminathan formed a qualitatively similar study on children who had meconium aspiration syndrome as infants. Now, this was relatively mild meconium aspiration syndrome. They did not require ECMO, for example. So compared to controls, adolescents who had neonatal meconium aspiration syndrome had airway obstruction, hyperinflation, normal aerobic capacity, and exercise-induced bronchospasm. Rafika Muchu Ersu, pulmonary fellow from 1998 to 2001, performed a study in children age 11 who had been on ECMO for neonatal respiratory failure. And note she studied 50 of these children and 27 controls. They were at about age 11. The reasons for ECMO were meconium aspiration syndrome, sepsis and pneumonia, congenital heart disease, all of which were repaired completely at the time of testing. Primary pulmonary hypertension in the newborn and respiratory distress syndrome. In this group of neonatal lung injury children, adolescents who were treated with ECMO for neonatal respiratory failure had airway obstruction, hyperinflation, decreased aerobic capacity, mild hypoxia during exercise, and exercise-induced bronchospasm. Exercise-induced bronchospasm or acute bronchial hyperactivity is commonly observed in adolescents after neonatal lung injury. Decreased aerobic capacity may be observed, and gas exchange abnormalities may occur during exercise, even with normal aerobic capacity. So exercise can be useful in picking up abnormalities in response to early lung injury, for example. Exercise in chronic disease. So in the early 1980s, optimal exercise prescriptions for children with asthma were controversial. Some recommended, matter of fact, most recommended, only exercise unlikely to provoke bronchospasm, and the key actor here was often swimming. Others encouraged any forms of exercise. So the question legitimately was being asked, is it safe to exercise children with severe asthma by distance running? So Bruce Nickerson, who was a fellow with us from 1979 to 1981, performed this study. At the time, it was not uncommon to have homes for chronic asthmatic children. Some believed that there were psychological components to asthma, and getting them away, getting severe asthmatics away from their parents might in fact improve their asthma. And so there were a number of these homes for chronic asthmatics around the country. This one was in Sunland in the Los Angeles area called the Sun Air Home for asthmatic children. And you can see here the dorms, swimming pool, rec area, dining hall, etc. In this home. So Bruce took 15 children. These were the ones whose parents consented, who had severe asthma, and by this we mean in a home for chronic asthmatics, systemic steroid dependent. And they ran up to 3.2 kilometers or 2 miles on a grassy field in summer heat and smog 4 days a week for 6 weeks. Pulmonary function, daily peak flow rates, aerobic fitness, exercise-induced bronchospasm, and ventricular muscle strength and endurance were measured. We actually referred to these kids as the lung distance runners, as you can see here. 15 patients, 75% males, 11 years of age. Note that they had normal total lung capacity, they were not restricted. FRC was a bit increased, although there's a wide variation there. FEV1 was decreased as a group. FEF 25-75 decreased as a group. And maximum voluntary ventilation also decreased as a group. This was designed as a 6-week control period, so they were studied at baseline, after a 6-week control period, and then after 6 weeks of running, as mentioned, 4 days a week on the grassy field, up to 2 miles, 2 miles each time. And you can see that there was a significant improvement in the distance run in 12 minutes, indicating that they did have an exercise response or aerobic training response to the exercise. Daily average peak flow was shown here and did not change, was not worse during the training period. We did an exercise challenge on a bicycle ergometer to assess exercise-induced bronchospasm. This was done intentionally because this was not the exercise test that was used. So we wanted to look at EIB, not exercising the muscles that were being trained. So baseline control training, you can see that heart rate and maximum exercise not different. Minute ventilation at maximum exercise, not really different between the groups. Maximum oxygen consumption, in this case liters per minute, seemed to be a little bit lower in the latter two phases, but it was not statistically significantly so. Airway resistance, FEV1, and FEF 25-75 did not change following exercise to assess CIB in the individuals here. I think you can see that there's no difference in their change in function following exercise. So basically, the training period did not make their EIB or airway hyperactivity worse. We talked about ventricular muscle strength and endurance previously. Using Bruce Nickerson's technique, we measured both MIP, maximum inspiratory pressure, which is ventricular muscle strength, and SIP, sustainable inspiratory pressure, which is ventricular muscle endurance. And again, these did not change over the course of the period with or without training. After a 6-week distance running program, children with severe asthma had increased aerobic capacity, but no change in lung function, no change in exercise-induced asthma, no change in ventricular muscle strength or endurance, and therefore we concluded that it was safe for children with severe asthma to exercise by distance running. I think now we would accept this, but at the time this was fairly novel, and both Dr. Nickerson and I were popular speakers at a variety of conferences to discuss the results of this study. Turning to a different group, people with advanced lung disease due to cystic fibrosis have pulmonary limitation exercise. This is often associated with hypoxia. So what is the exercise performance in patients with severe lung disease? And can supplemental oxygen improve their performance? So Carol Marcus, who was a pulmonary fellow 1987 to 1991, she exercised people with severe CF, and she defines severe lung disease as having hypercapnia on a blood gas at rest. So CF subject and control subject performed 2 graded exercise stress tests. The cardiopulmonary exercise tests were randomized, one breathing room air and one breathing a fraction of inspired oxygen concentration of 30%, and subjects were blinded to the FiO2 that they were breathing during the test. These are the groups: 22 CF patients, 21 controls, slight preponderance of males, median age 26 in the CF, 29 in controls, age range 14 to 46 in CF, 19 to 37 in controls. Height comparable, weight not surprisingly lower in the CF patients. At rest, total lung capacity was not different between CF and control. Hyperinflation was present. The RV-TLC ratio was over twice in CF what it was in controls. FEV1 was lower. FEV1 over FVC and FEF 2575 all were statistically significantly lower. Again, not surprising. Oxygen saturation was lower in CF patients. Arterial oxygen was 64 by a blood gas, not done in the controls, and PCO2 was 46, so they did have some CO2 retention. During graded exercise stress test, the duration of exercise on a standard protocol was slightly greater breathing supplemental oxygen with the blue. On controls, also slightly greater. Maximum heart rate, not really changed when breathing room air or supplemental oxygen. Maximum respiratory quotient, or the RQ, again, not significantly different between oxygen, room air, and oxygen for either CF or controls. Maximum oxygen consumption was slightly greater in CF patients breathing supplemental oxygen, but not in controls. Controls obviously had a higher maximum oxygen consumption. The oxygen pulse correlates some with stroke volume, increased in CF but not in controls. Anaerobic threshold was not different either in CF or controls with supplemental oxygen versus room air. Minute ventilation was the same in CF but did drop in controls. And breathing reserve, again, was the same in CF and did increase, reflecting the drop here in controls on oxygen. The ratio of tidal volume over forced vital capacity did not change in CF. It dropped a little bit in controls. And maximal CO2 production increased in CF, meaning that they had increased metabolic rate, could exercise better, and did not change in controls. Maximal ventilatory equivalent for oxygen fell in CF, meaning that their efficiency was better on oxygen, didn't change in controls, and the ventilatory equivalent for CO2 actually increased slightly in CF, again reflecting the increase in CO2 production, and did not change in controls. The fall in oxygen saturation at maximal exercise was obviously greater in CF. It wasn't significantly different in controls, but they didn't have much fall on room air. The increase in end-tidal CO2 was significant in CF, whereas in controls it actually fell. The increase in PCO2, this was end-tidal transcutaneous, showed the same trend. The increase in CF was not statistically significant in the controls here. So hypoxia was obviously eliminated in the CF because of supplemental oxygen, and CO2 increased some because they could exercise further and therefore generate a greater metabolic rate. So supplemental oxygen in people with CF and severe lung disease who were hypercapnic increased the duration of exercise of cardiopulmonary exercise stress test, increased maximal VO2 and maximal O2 pulse, increased maximal CO2 production, did not change maximal ventilation or breathing reserve, decreased ventilatory equivalents for oxygen and CO2, meaning more efficient pulmonary system, reduced oxygen desaturations, and increased PCO2 at maximal exercise. So exercise performance is limited in CF patients with severe lung disease. Aerobic capacity is reduced, indicating decreased fitness. Breathing reserve is reduced, indicating pulmonary limitation exercise. Hypoxia occurs at maximal exercise. Supplemental oxygen improves hypoxia and increases aerobic fitness, and supplemental oxygen during exercise is likely to improve quality of life. So what have we learned about exercise? Strength or power sports use muscle energy from muscle stores anaerobically. There's no time to deliver oxygen to exercising muscle to generate energy. They build up an oxygen deficit, is what that should say, which is repaid at the end of the event as oxygen debt. Aerobic exercise requires muscle energy production. O2 must be delivered to exercising muscles to generate energy. Cardiac function is required for O2 delivery, and the normal limitation to exercise is inability to deliver more O2 to exercising muscles or inability to increase cardiac output. One can still increase minute ventilation at maximal exercise. Thus, pulmonary mechanisms do not limit exercise in normal subjects. Training increases maximal oxygen consumption and anaerobic threshold. Pulmonary limitation exercise occurs in lung disease, but it is not normal. Pulmonary limitation to exercise is evident by decreased breathing reserve, fall in saturation, increased PCO2, and/or increased ventilatory equivalent for oxygen. The physiologic challenges required in heavy exercise mimic those required during critical illness. Next time we'll begin our four-part discussion of high-altitude physiology. Thank you again to our director-producer, Dr. Catherine LeWinter, and thank you again for joining me for this, the great adventure, pediatric pulmonary physiology.